I'm Allison Bond of DOM Grand Rounds, and I'm very excited to introduce Dr. Gina Solomon, who we have today. She's the chief of the Division of Occupational, Environmental, and Climate Medicine at UCSF, where she oversees clinical, occupational, and environmental health at UCSF Health, the General, and SFVA. Take it away.
This live, great. I am very happy to be here today to welcome you to the 32nd annual Alice Hamilton Lecture. We've been doing this for a while, and I am happy to introduce our speaker today. But before I introduce our guest, I'd like to just take a moment to speak about the legacy of Alice Hamilton. Although she was never actually at UCSF, to my knowledge, she would have fit in really well here. She is definitely an inspiration for our division and for our work. And part of why she's an inspiration is that she was an amazing woman leader in medicine. In the 1890s, when she went to medical school, there were fewer than 5,000 women physicians in the entire United States. And then when she left medical school, her career initially focused on treating poor immigrants in Chicago for diseases that she began to realize were often due to their work. And so this led her to conduct pioneering investigations into everything from lead poisoning in workers, mercury exposure, the health effects of industrial chemicals, and then to take that scientific work and move it towards advocacy to improve the working conditions of those workers. That's really, I think, an important link here to her work. In 1919, she became the first female faculty member at Harvard Medical School. The New York Tribune wrote a piece about it, and the headline was, "A woman on Harvard's faculty, the last citadel has fallen." And her faculty position actually came with 3 stipulations. I think we've talked about this in previous years, but I never tire of this. Number 1, she couldn't go into the faculty club. Number 2, she could not get football tickets. And number 3, she was not allowed to march in the commencement procession. And worse, actually, in my view, she was never promoted. So she retired still as an assistant professor, even though she's really one of the greats in our field. But she was an activist throughout her career. She advocated for the rights of workers, immigrant workers in particular. She was very focused on anti-militarism throughout her career and even in her retirement against the Vietnam War, and fighting McCarthyism in the 1950s, all lessons that we can still hold close today. So it's in that spirit that I want to welcome today's speaker, Professor Isabella Anesi Maisano, whose work has significantly increased our understanding of respiratory and allergic diseases, particularly in relation to environmental and occupational factors. Professor Anesi Maisano has devoted her career to studying the impact of air pollution, climate change, and other environmental exposures on lung health, and shaping policies that protect public health worldwide. Her academic journey is as impressive as it is diverse. She has a background both in physics and in medicine. She earned advanced degrees in epidemiology and public health from the Université de Paris 11 before completing a postdoctoral fellowship at St. George's Hospital in London. She had a brief stint at the University of California, Berkeley, just across the bay. And then since 1983, she's been a leading researcher at the French National Institute of Health and Medical Research, or INSERM as we know it, where she directs the Department of Epidemiology of Allergic and Respiratory Diseases. Oh dear, I think that's my phone that's ringing, sorry. Her research has contributed significantly to the understanding of gene-environment interactions in asthma and allergies, effects of early life environmental conditions on immunity, and the respiratory implications of climate change and wildfire smoke. She's led international collaborations with the World Health Organization. She's done epidemiological studies across Africa, French Polynesia, and New Caledonia, and contributed to global initiatives to reduce the burden of respiratory disease. She's also done great work on indoor air quality in schools. So she's also a great educator, leader in her field, and is currently a professor at the Université de Paris 6 and the Université of Montpellier. And she mentors graduate students and has held key positions in the European Respiratory Society, among others, and has authored nearly 500 peer-reviewed publications. And her work really exemplifies, in summary, the legacy of Alice Hamilton. So we're really glad to have her here, and please welcome me in welcoming Professor Anesi Maisano to the podium. Thank you.
Thank you, Gina, for such a nice words, too much for me. And actually, I'm really honored to be here for the Alice Hamilton lecture because I always admired this woman. So I think for me, it's an honor. I'm going to talk about air pollution, asthma, and allergy in this exposome year because this is what I'm doing recently, and I will try to show to you why I'm doing this line. As I said by Gina, for me, policy, public health are very important. This is why I have no private conflict of interest, no farms, no pharmaceutical company, but I'm in many committees, as you will see, that are public, and obviously I'm in medical society. And to just underline, I'm in ethics committee. One is the ERS, it was before with the Ben that is there. And we did, I hope, a great job. And another is the national one. And then please take into account that I'm a section editor for environmental health at the ERJ and the Union Against Journal of Tuberculosis and Disease. So submit because I really defend the field. So I will start with some questions, try to reply to this question. Why asthma and allergy? Why air pollution? Why disposome? And what observation and insight? So there are 339 million people worldwide affected by asthma. These are the last figures by GINA, the Global Initiative Against Asthma, and also WHO. So we can think that asthma is one of the most common chronic respiratory disease globally in the world. For children is the first one. As you can see, there are still avoidable death for asthma, almost 500,000 million. Many are in this country. Unfortunately, this is really related also to socioeconomic status. These people, some people suffer from the disease every day, still related to health care. Many people don't know a lot about their problems. 55% of people say their asthma affected their work, is even related to the work. Ben and other people here, you are many, mostly occupational doctor, so I don't go in depth in this, but last line is very important. Asthma and allergy are increasing according to WHO. By 2050, 1 people out of 2 will be asthmatic or allergic. These are projections. So why this increase? I love it so much. I was young, this editorial by Anthony Sinton that said discussed the hypothesis according to which increase of asthma was because of a more toxic environment and or a more susceptible population. When I used the term susceptibility, it was the general term, but actually we have to make the distinction now, just like WHO is suggesting, between susceptibility, so children, pregnant women, people that are suffering from some disease, elderly, and vulnerable people. These are the people more exposed with less affluent, etc., because they have a more exposure, a higher dose, and so a more probable impact. Why air pollution? Air pollution is one of the greatest environmental risks. Every day, you can find at least one article on air pollution in very important journal, as you can see, everywhere in the world. And according to last data on mortality, this is the Bauer team in Canada that estimated 10 million deaths, but probably this is an underestimation. I will show to you why. I want to underline what Ghebreyesus, the WHO Director General, said. Air pollution is the new tobacco epidemics. So we really need to take into account this risk factor. Why? Because this is an avoidable risk factor in theory. So let me say something about air pollution. Contrary to other risk factors, environmental risk factor, air pollution is ubiquitous. The WHO made some estimation. 99% of the world population is exposed to air pollution, which concentration is higher than the air quality guidelines. So 99% means pollution is everywhere. And why? Because pollution is man-made, is natural. There are several sources. I will show to you briefly some sources. And then when you have the emission of the pollutants, this can be transformed, then they impact with the weather, according to humidity, rain, etc., wind also. There is a dispersion. It's only at the end of these processes that you have impact on people, and unfortunately not only the people, also the environment. So there are two kinds of pollutants, the particulate matter, and I will show to you better in detail, and the gases. And they are very many, but here I'm underlining those that are regularly monitored, because many, unfortunately, are not yet monitored. The sources for man-made pollutants are domestic combustion, traffic, industry, energy production, agriculture, forest, and you recognize the pollutants that we see very often on the paper, on scientific or not, nitrogen dioxide, sulfur dioxide, volatile organic compounds, ammonia, and also ozone, which is a secondary. Then we have the natural sources. The pollutants are almost the same, and with John, but I work a lot with John Burns, we have just a paper almost accepted by the ERJ, and not because I'm the section editor. This was an independent process on natural disaster respiratory health, because we think that it's worthwhile to underline it, also because they are not so natural. They are anthropogenic too, in some extent. So you know everywhere about pollution USA, so I'm going to show to you air pollution in Europe. So where is the bad pollution in Europe? All mostly in previous URSS countries, because they have a lot of industry, they burn the coal, etc. But as you can see, for PM, my country, because I was born in Italy, has a lot of pollution in the Po plain, Milan. It's a really, really bad pollution. For the rest, NO2 is present everywhere. There is traffic. So Paris, Marseille, for example, in France, but also Rome, etc. Ozone is where in the southern part of Europe. And then, unfortunately, in Europe, we still have some bad pollutants like benzalpyrene because they is still used in the eastern country. What about the improvement of the air quality? On the right, you have the evolution of emission of pollutants and also the GDP. GDP, as you can imagine, is increasing slowly, but as you can see, some pollutants are really disappearing. For example, SO2, because we have externalized production of SO2 in China, India, etc. So there are less industry. For example, close to Paris, no more industries at all. There are in Lyon, but not. But when you go on the left, this is the average PM 2.5, the fine particles that I will introduce to you. And as you can see, this is still fluttering, and the red line is the WHO standard. This means that in any case, the concentration is too much elevated, take into account what the WHO wants for health, public health. And it's even so, if we discuss these, unfortunately, these data come from monitoring stations that are fixed in some places. So it's a underestimation of the real exposure. But what happened when we take into account that, unfortunately, we are not following the WHO recommendation, but we are in Europe following the EU directive. As you can see, for example, for these famous fine particles, 2 micron and a half, according to WHO, up to 81% of population is too much exposed, whereas for the Europe, only 8%. And this is the same for all the pollutants. So we are not protected. As said by Gina, we don't have to forget that indoor air is also bad. And I like very much this picture because people thought so much that it was bad indoor air that they made in UK and even USA porch to put the kids. If you go to see in Google, you find millions of pictures of this type. So what the pollution they were aware of, it was more molds, bacteria, etc. But still, this means that there was a consciousness of the danger. So let's go back to particulate matter. They have 2 characteristics that are important. One is the size, because according to the size, they go deeper in the airways. And the 2.5 size are here. They can go to the bronchi. When they are, these are the fine particles, 2 micron. And that you have here in the upper part, how much is a fine particle compared to air. And the smaller, they go deeply in the lung. And then when they are ultra fine, they go to the alveoli and they can cross the barrier and then they go where? In the blood. And this is why you can have air pollution related to many diseases that are not respiratory. So cardiovascular disease, I'm not going in detail, but there are many, many publications indicating that there are effects on various organs, very important, the brain, for example, with neurodegenerative diseases. And I will show to you some impact at the population level, but just 1 second to stress that pollution has an impact also on the environment, biodiversity, crops, climate change. This is really important. Built environment, and obviously economic cost, because air pollution costs 6.1% of the global GDP in the world. These costs can be reduced. Here in USA, you have a very nice publication, New England Journal of Medicine, that probably you know, that probably John was the reviewer. In any case, on mortality and air pollution in the Medicare population. This is an important publication for 2 reasons. One is, as you can see, there is this slope, no plateau effect of pollution. So some people, mortality happens with very low concentration of the pollutant. This was true for both particulate matter, fine, and ozone. So that the author said that the effect can be seen at concentration below current national standards. And the second important results, because they had many individuals, including the studies, that this effect was most pronounced among racial minorities and people with low income country, because they are more exposed, because also they have less access to health care. So just some slides on asthma burden in relation to air pollution. There are 2 kinds of effects. Short-term effects, you are doctors, so you have seen people arriving with asthma attacks because there is pollution, probably not so much here in San Francisco because it's windy, probably, but yeah. Good point. Anyway, you have it, sure. And then a long-term effect. And for short-term effect, I like really much this publication, McCreenor, New England Journal of Medicine, once again. They had this very good idea to ask mild asthmatics to go to walk Hyde Park and then to the other place, Oxford Street. And now it's a different Oxford Street. They have diminished the relation. And then to cross. So crossover study to study the effect of air pollution. And the effect was that the lung function, FEV1, FVC, were reduced by this walking for 2 hours in the polluted places. And there was also some change, there were changes with increase of biomarkers of neutrophilic inflammation in sputum. And what is fantastic in this story is that after this exercise, people were normal, went back to the normal. So we have here a proof quoted of the fact that there is a short-term effect. Obviously, we need more, and in epidemiology, we like very much this kind of nasty figures that are the meta-analysis, and these are meta-analysis or asthma exacerbation, their pollution that is under press. We found for any kind of pollutants, ozone, NO2, but also SO2, for example, that was a significant relation. But this is not enough. And we have to go towards the incident asthma. And this is a paper by Annenberg, I think Dr. Annenberg, you know, she's in USA, and that found that almost 2 million new pediatric asthma cases were attributable to NO2 globally, because you can see, I'm not going in detail, but here you have Central Europe, income countries, Latin American, etc., etc. There is even USA, but for a small amount of data. So we have some data in some way suggesting that there is a relationship. Once again, this is the one with John too. Sorry, the quality of the image is not good, but it's my fault because I can see better here. Anyway, and then we recovered cohort studies to see what happened for asthma development and air pollution in children, mostly, that were not asthmatic before. And we found for NO2, for black carbon, for PM2.5. As you can see, according to the kind of pollutants, there are more or less data. So at this point, I need to shift the paradigm. And in two ways. One way is that we know that asthma is a multifactorial disease. I have this discussion every time I go to the French parliament. They tell me, but asthma is not caused by air pollution. So with Francesco Forestieri, we wrote this editorial in which we said that we have to think differently the causality. We have to think the cause factor is any major in a multifactorial disease, any major contributor that, if eliminated, would have either prevented the occurrence of the outcome or reduced its severity or frequency. And with that, this is my my point every time I go to see those, they say, no, there is no causality, so it's non-important to reduce air pollution. And the second street of the paradigm is thinking larger, because air pollution is not an isolated factor. So let me introduce the idea of exposome. This idea was brought up by Chris Wild, that was the director of the International Agency Research Council, WHO agency in Lyon, that was trying to understand because cancers were increasing so much. So he said that we need, just like in the case of genome, to build an exposome, which is the totality of exposure to which an individual is subjected from a conception to health, because a cancer is in adults a long process. So certainly exposure during life met. And he said that we can think about an internal exposome, which comprises all the process internal to the body, such as metabolism, gut microbiome, inflammation, that follows what? External aggressions, environmental, of the external exposome. And the external exposome is either very specific, so what is encountered by the individual, infectious agent, chemical contaminants, diet, or generic. So the social context, economic, and psychological influence. Taking this into account, he said that we have to think of the interaction among the three domains as the origin, as contributing to the origin of chronic disease. And in the case of asthma, wow, look, everything is connected here. It's like a little bit messy, I agree, but every arrow as an hypothesis, sometimes it's really well shown, demonstrated. So outdoor pollution, obviously, I'm not commenting everything, but air pollution is related to indoor pollution, is it related to climate changing, urbanization, green, gray, blue spaces, biodiversity, Allen Pondle malls, biocontaminant, and obviously on the left you have all the natural catastrophe, disaster we were talking. Obviously, there is also the social context and the occupation, and these factors have an effect with the genome because of gene-environment interaction, and always also on epigenetics. Recently, I have some paper showing that air pollution impact methylations. And so, obviously, once again, we have to think about increased susceptibility and vulnerability of people. So the idea of the exposome is to assess, I said, from conception to death. It's a lot of work. So what can we do? We need a very good assessment. Here you have some of the ways we use to assess that. Obviously, questionnaires, even barcode, very useful for knowing to what the people are exposed. For example, sprays in the house if you clean too much, I should say. And then wearable sensor. I have in my bag one sensor we are using, which is the small over there, real-time exposure with GPS, but also when there are no resources, can be done with the satellite. Here in USA, you are very strong with the NASA satellite assessment of pollution. Can be drones. So we do everything because we need the data. And so now to move to beginning of a link of the exposome for air pollution, let's start from climate change. What, there is this language virtually certain or not, and for virtually certain, we have many data on the pollens. We know now that because of climate change, the rain, temperature, we have extended pollen season, pollen production, and allergenicity. We have also, that can be also due to plants that move because they like better one place than another. Then we have also increased outdoor ozone because increasing temperature, urbanization, and increased outdoor PM, which are due to increased man-made emission from fossil fuel in urban setting. You know that by 2050, 70% of the world population will be in a town with the mega city, very, very important. And then the natural disaster we were talking about previously, PM increased because of wildfire smoke, because of drought, desertification, sandstorm. And unfortunately, look at the last line, we don't have a data on indoor pollution because it's difficult to work on that. So here, once again, a meta-analysis investigating the effect of dust storm on morbidity and mortality due to cardiovascular respiratory diseases. That they found not so many studies. This is a problem, but an effect. And then this is another study, still a global study with data coming from different countries on dust storm, a risk of asthma exacerbations with a lag of 0.5 days. The worst effect was for 2 days. And then this is a paper by Kari Nadeau. John, I was surprised that you have not signed this, health effect of wildfire smoke exposure, and in which she and others made the point on mortality, wildfire, and this is all-cause mortality is related, respiratory mortality too, but in terms of hospitalization, the visit only respiratory, not cardiovascular, because the mechanism is different. Now, what is probably less expected is that asthma, severe asthma attacks also is related to pollen, which in principle we think pollen and hay fever. And checking the literature, we have found this initiative we had as a European Academy of Allergy and Clinical Immunology, and we found that there was a significant effect. As you can see, very few studies, so we have still to be cautious. And then, because I'm talking about the climate change, I have to underline, we can discuss that after, of the thunderstorm asthma, which is really an example of climate changes, because as shown in the figure, pollen go up just before the rain starts. And when they go up, they find the moisture of the cloud. So there is a liberation of the allergens. And then because of the wind, that in general is strong enough, there is a return of these allergens down. And this is why people with hay fever, usually with their fever, can have asthma attacks because they met small submicronic particles. And in Australia, because they had many people going to the hospital after storms, they had even 10 deaths for this. But I want to show another interaction which is of interest, and this is the pollution and pollen. So that interact, and I will show to you some experimental data picture. So in some way, the region, an allergy release by the pollen, and then two possibilities. On one hand, there is the particulate matter that is a carrier of the allergen. And on the other side, there is an allergenic aerosol with, including many things, and does also the pollen allergy. And I think nothing is better than seeing this picture. On the right, you have atmospheric PM that are adhering onto pollen. It's the same here, but down you have allergen from pollen, and not only pollen, that are transported by combustion particles. And the second phenomenon is this one. Because of air pollution, the actin of the pollen open up. And look, there are a small particles, the submicronic particle I was mentioning before, that enter in the aerosol, general aerosol, and then can be inhaled. So some data on that, but this is a synergistic health effect studied in a systematic review. And now also some from the Imperial College finding that there was an effect, but obviously, as written, only a third of existing studies identified a significant allergen pollutant interaction using a good epidemiological study, because the problem are biased here. So I'm showing to you another way to consider that, which is a complicated way. So we studied for 8 cities in France, the interaction between pollen, air pollution, I'm showing now for particulate matter, agriculture, and the land cover. And this was for 2 kilometer resolution. And we want to know whether, according to the cluster of these factors, the asthma drug sale differed. And then we did that. What's that? Each pile are the 12 months of the year. Okay, so the first is January, the last is December. And this you have a small resolution. The blue is the nasty one because, as you can see, a lot of asthma sales, pollen were there, pollution, a lot. The agriculture was not there, the urban setting was there. So in some way, what we have shown in this, that has to be taken with a lot of caution, because you can buy medication, but not take them. Yes, but in general, for asthma, you know. So we had, this is only for 2 towns, more drug sales in urban zone with polluent. What are the air pollution action? I think that we can mention that this is the perfect demonstration of the epithelial barrier hypothesis that was raised by Chesney Atkins, according to whom epithelium, which is a robust physical chemical barrier protecting its body from environmental aggression, is broken by air pollution through 2 mechanisms: enhancer airway epithelial permeability, which through microbial dysbiosis, so increasing the susceptibility to respiratory infection, risk of asthma, etc. And then a second mechanism, exaggerate inflammatory responses and airway modeling that are key feature of asthma. Sorry, I had to. Voilà. So on the left part, you have a healthy airway epithelium. On the right, PM arrives, the tight junction opens, and they room have, as a consequence, all the mechanisms you see, the reactions that are very, very complicated, but can be summarized in some way as immunological changes, mucociliary dysfunction by reducing cilia number, a global cell metaplasia, production of immune cytokines that further impact airway epithelial barrier dysfunction. And then this has also been studied, and there is a change in the microbiome. And now there are very interesting studies on lung microbiome, etc., but I'm not mentioning that. But you see that the family of the kind of microbiota change from Bacteroidetes formicula to many other bacteria that then from the upper airway migrate down to the lower airway. It can be pathogenic. So, wow, after that, I think you are convinced that we have to do something. What can we do? I showed things that are very difficult to do, but I introduce this notion of what I call the modifiable, editable, probably is a better English, exposome, which means what are the factors for which an action is allowed. And I organize my thought in this way. There are factions that have a major impact against which we want to go, factors that have a minor impact, and then we know that sometimes this can be done at the community population level on the right, or at the individual level. Quitting smoking for me is individual, even if I know sometimes is related to other conditions, so not so easy. And as you can see, for air pollution, green space, lack, that's the idea, pollen, biodiversity, we know that the impact is there, and we can also act. We can discuss that because how can we act on pollen? In France, we have a monoculture in Paris as a tree. This is the name, but this is Ben Lefren, do you know? Okay, anyway, I will tell you. So in some way, we can avoid some stuff. So to go back very quickly, how much time do I have? Because I like talking, but it's 10 minutes? Yeah, perfect. So I take the initial slide to see that obviously we can act in terms of the sectorial legislation, transport, industry, products, that we have to fix air quality directives with legal standards, assessment air quality, management air quality, information to the public, etc. But what we need more is the proof that it works. Here in USA, you have a very nice study in California where they changed the county pollution and then the lung function growth well. This is very famous, you know, so I'm showing something more original from Sweden. This is the BAMS study. It's very important because a decrease in ambient air pollution exposure, even at relatively low levels, is associated with improvements in lung function growth from childhood to early adulthood. And that's really, really important because we need, here you have the amount. So it's a very important paper. And then another paper for Europe, Anne Kreis, other colleague we know very well that are very active in the field. So here you have the total case attributable to exposure, etc. But what is important is that 60,000 case of asthma per year could be prevented when complying to the WHO guideline. So, which is a lot, obviously. And then this is another simulation done by the European Environmental Agency, reaching in Europe the 2021 World Health Organization of 5 micrograms per cubic meter would imply at least more than 200,000 avoided deaths. And so 58% of premature, I don't like very much this term. And as you can see, this really depends on the country. 0 death avoided in Iceland, yes, at least, and 76% in Bosnia and Herzegovina. So obviously, we have to take into account this complexity of the situation. And this slide is from Steve Holgate, saying, and I always put it in when I can, obviously, that beyond the CO2, there are many other equally dangerous gases that we call the short-lived climate pollutants, against which we have to fight again the climate changes. And I think by 2100, full mitigation CO2, a short-lived climate pollutants could reduce the rate of sea level rise by up to 50%. But if you take this report, the UK report on climate change, we will find many data. So it works, and it's worse in the short term because 45% of current global warming will be in some way mitigated by acting also against these short-lived climate pollutants. And then it's my almost last. I like the idea of a natural-based initiative from Attila in Finland. You know, they have the Finnish allergy program that has worked well, if you look at the figures. And these, they are few, less than in Sicily, as I say, because they are few people, but they want to have many action, many initiative, obviously no pollution, no smoking, but also soil connection. They have a nice paper showing that when children play with the earth, they are protected. Fresh fruit, berries, vegetable, outdoor activities, animal contact, through obviously this immune balance that for which there is a recovery when you have a rich and diverse microbiome. And then obviously also the indoor setting as not to be forbidden. And then I want to finish with this paper. John is one of the authors on climate change and respiratory health, opportunities to contribute to environmental justice. This is an official, probably someone else in the room, sorry if him too is already among the authors, no, okay. And official American Thoracic Workshop report that in some ways considering the exposome too, but from the point of view of the activities to stop at different level, individual level, family level. I have not thought about the family level, but this is in my previous slide on the exposome, community level, a global societal level. So activity to stop, activity to start to address this issue, because vulnerable individuals are more exposed to environmental hazard. I think this is a long paper where everything is well described. So just to say a summary of what I have presented, air pollution is ubiquitous. Many pollutants, as you have seen, I have targeted some pollutants. There are many overall indoors. And we don't know, we don't have a data on that. All air pollutants impact human health. Particulate matter is the most worrying. We don't know the effect of all the other pollutants. Air pollution impact health, even at low concentration. This is really important to be said. And the impact is higher in most deprived region and people. Air pollution is not an isolated factor, so we need the exposomic approach. This is my point of view. We can discuss. And we have to identify and act on the modifiable, avoidable exposome. And air pollution diminution is effective, as I showed to you with the data on Europe, and also the Swedish data on lung function growth in the case of reduction. And I thank you very much for your attention.
That was wonderful. That was wonderful. We have a couple minutes for questions. I'd love to ask one of my own, and then I'll open it up to other folks. So how does all this knowledge kind of change what you do every day? Like, are you on your phone looking at sort of the particulate levels and wearing a mask outside, or, you know, how do you weigh things as an expert like this?
Unfortunately, not this kind. I would like, I don't see any more patients, so I would do if I had some patient to follow. But sometimes I have people calling me because they are exposed. So at that time, I give my point of view on what they can do. Yes, what I do in general, it's, for example, next Monday I will be at the Brussels Parliament to discuss about, to try to push them to go towards the WHO standard, etc., and more on the policy side, I should say.
Would you walk along Oxford Street for 2 hours, like in that study, or what do you do as a?
Paris it's quite polluted in spite of what the mayor is doing. You know why? Because when you reduce the street, then you have a traffic jam. And then also this idea, have you heard about the ring, the périphérique? They put the the speed of 50. And then that means that there are many traffic jams, and then every time you stop, then you go again, and then it's a production of. We don't have so many electric cars as I think you have here, and even the last data are bad because people are no more buying. In France, we have 10 million poor people. It's a lot. The population is 67. These are monofamiliar families, very often, women with kids. So they don't buy electric, it's too much expensive. If they buy overall in the rural side, etc. That's why there was a sort, probably you read in the newspaper, Gilets jaunes. They were against the raise of the price of the diesel, because they couldn't afford. Some people drive 80 kilometers for going to the work and then come back. And then obviously this is to be taken into account.
We've got time for maybe one more question. Anyone in the audience?
Thank you so much. I super enjoyed your talk. You presented 4 ideas that I think are sort of in tension, but not impossible. But for people like me who are not as efficient with their time as you and can't put out 500 papers, I'm wondering which of these you think is the most useful thread for medicine to pursue. One is the idea of a component cause, where like a risk factor is contributing a lot to diseases across many different etiologies. And that's like the EWAS approach or some of these other things. Another is the idea of these combinatoric things like polluant. Another idea is that environments are changing, and the set of things that are changing in the environment may not be the same set that's disease causing. Polluant was a nice example where climate change is exacerbating both exposures. You could think of like water quality changes where some things are getting better and some things are getting worse. Do you feel like we should be studying the changing environment as it is changing? So the changes we forecast for risk factors and the set that we anticipate in the future, what that's going to do to public health? Do you think we should be focusing on a clear message of this is a risk factor that we need to control, policymakers, please ban this? Or do you feel like we should be talking about etiology and saying this is the set of things that will make people the most sick? We have to prevent that combination from happening.
I think it depends on the audience I have. So when I meet a member of the parliament, I go really to the essential. In that case, the short-term effect is really important, knowing that because I was dealing with the respiratory disease, but infarctus is really related to cardiovascular disease, etc. And so this is important. Children having, we had an European study with pollution in the schools, 2% of the children, the Symphony study, had asthma attacks in school. And this was in the classroom where we had too much pollution. So this is an important issue. And so in some way, I agree. You had a very good comment on all the 4 strategies. I think it depends on the audience. It depends also to whom you are talking. And then also what is feasible. Sometimes it's better not to. So for patients, we are writing one paper with the idea of what the physician has to say to patients. So probably wait for the next talk.
Great. We're at time, but happy to take further questions at the front here. Thank you so much.